Good evening, everybody, and welcome to this evening symposium. Good evening, Professor Stephen Schreiber. Can you hear us? So, Stephen, can you hear us?
Yes, I hear well. Do you hear me?
Okay. Yeah, we can hear you. Thank you. So, we have all the experts in IBD, the core experts in India here this evening. This is a part of the meeting we are having on endoscopy in IBD, but this evening's meeting, of course, is going to be on vedolizumab. I'd like to welcome you to this meeting, and this is in two parts. We first have your talk, followed by Q&A by the experts here, and then we'll have a panel discussion which Dr. Rupa Banerjee would be conducting. Just to introduce Stephen Schreiber to this audience, of course, he doesn't require introduction. He's so well known in the field of IBD. He's mainly involved in the molecular pathogenesis of ulcerative colitis and, of course, lung disease also, incidentally. He's been part of the German GWAS, which is, I think, been responsible for many new gene foci that have been described. He's, of course, done a lot of work on the area of vedolizumab, and of course, he's going to talk to us on that. Stephen, it's over to you.
Yeah, thank you very much for inviting me. Let me switch on my camera here. And I'm happy to talk a little bit about real-world evidence data around vedolizumab, mainly focused also on some German data, which we obtained recently with the VEDO-IBD study. And Takeda has invited me very gratefully here to give this presentation and to share this data here with you. Now I need that on screen. Do you see the screen already?
Yes, seeing it on the screen.
You see it on the screen,
yes,
okay.
Yes.
Because I don't see it on the screen. Let me just bring it up for myself as well. Second, please. Also look at parallel at the slides because I don't see the slides. But if you see them, that's fine. 1 second, please.
You're seeing them well here.
Yeah, I don't see them. But that doesn't matter because I have a copy here and I can look at a copy. That's no problem. So, okay. No, fine. Yeah, I see them now too. Perfect. So, next slide, please. Second slide, please. Yeah. It shows my disclosures. So, you see the slides?
Yes, we can see the slides. Yeah, now your disclosure slide is on.
Okay, perfect. So, next slide, I would like to talk particularly on the early use of vedolizumab. And the reason why I want to talk on the early use is because that's a theme which you will see later coming on also on the real world data. And that's, I think, a very important theme because indeed, probably doing a trafficking inhibition like blocking the alpha-4 beta-7 integrin is not just valuable for the late disease, where it also works, but probably particularly valuable for early disease. And if we look at the next slide, please, we look at the endoscopic healing. You see that earlier is better in general, not just with vedolizumab. It is a general theme we see with all of the therapies. Making the right choice early on matters. This is data from the so-called CALM study, where patients were exposed to high doses of adalimumab at a very early time of the disease, below 1 year of disease. You see it makes a big difference whether after the 1 year of therapy, they receive endoscopic remission or even go into deep remission, which is a combined endoscopic remission with clinical remission plus no inflammation marker anymore. And you see this here in these different graphs that show you disease progression, defined as new complication, new stenosis, new fistula, longer hospitalization or operation. And you see indeed it makes a big difference where you go and how far you can push the patient. The next slide looks at vedolizumab in early patients. That is the next slide. Now, on one more, slide number 5. Yeah, and here we see that in early patients, especially these early patients, indeed, if we are using vedolizumab early, that we see advantage over the anti-TNF. And you see this here with clinical remission and mucosal healing. And you see this over a total period of 24 months. You see a difference, which I think is sizable. It's about 10% of the entire patient population. And if we look at the percent for treatment success, it's almost 20% of the absolute treatment success. And you see one more, I think, important part here. You see that vedolizumab is not slow. You see in the naive population that vedolizumab is as fast as the anti-TNF therapy when it comes to the therapeutic success. We go for the next slide, please. This is another way to look at data. It's a Versify study. It's a different cohort. It's an open label cohort that has received vedolizumab for the investigation of mucosal healing by endoscopy. And you see also here singled out the anti-TNF naive population on the left side in comparison to the overall population. You see the anti-TNF naive population is doing better, certainly. And you see that at week 26, you can also look at the week 52 data. Again, in the week 52 data, you see a better performance in the early population. But you see also that there's a lot of increase in signal between week 26 and 52, which also shows us, as the graphs before, that in Crohn's disease with mucosal healing, you have to give some time to the substance. Now, who are the patients with the most success? And if you look in the middle, you see the patients below 1 year of disease are the ones that are most lucky. And you see we are later in the disease, 3 to 7, over 7 years, things become more difficult. So next slide is also looking at time point of vedolizumab, looking at patients with low, intermediate, and with high risk of CD-related surgery. And if you look now in both populations, we see that the patients were below 5 years, show an advantage of the early use of vedolizumab. The advantage is particularly high in the patient with low and intermediate risk in comparison to the high risk. So vedolizumab early also to the uncomplicated patients. Next slide, please. If you look at another study, it's the EVOLVE study. Again, looking at the same kind of question, looking at bio-naive, non-complicated Crohn's disease and trying to see whether there's a difference between first-line choice of adalimumab and first-line anti-TNF and first-line choice of vedolizumab. And again, you see that in the non-complicated patients, there's a definite advantage for the vedolizumab in this study over the complex patients. And you see this very, very clear that, again, when you give vedolizumab early before complication, it is of particular advantage. Next slide, please. And if we start comparing, and this is a comparison in the Victory Consortium, again, between anti-TNF and between vedolizumab, you see the different disciplines here, clinical remission, endoscopic remission, steroid-free clinical remission. You see this in the patient below 2 years, shaded in gray, and then you see 2 to 5 years, and above 5 years, you see very clearly the advantage, I think, of vedolizumab over anti-TNF in the early patients, whereas in the later patients, it works also, but it does not work this score better than the anti-TNF. Next slide, please. Looking again at a different cohort, also from the Victory Consortium, and splitting up the patients into patients between 0 anti-TNF before, 1, 2, and 3 anti-TNF antagonists before. And you see very clearly that the vedolizumab performance is best in those patients who are early and who do not have failed multiple anti-TNFs. And on the right side, you see the different hospitalization and complications after 1 year of vedolizumab. Here, actually, you don't see that favor of early vedolizumab, but you see here very clearly also that there's a trend, at least, that the more anti-TNF exposure on the gray side leads to more problems. Okay, so that's the starting point to look at some more real-world data. As you see, next slide, please. And we start doing that now. Next slide. Yep. So we can go one further. And here, a real-world comparison is done now from a much, much higher viewpoint. So no longer look at cohorts that are charted with examinations from time to time. We now go to bird's eye perspective, which means we are looking at a high difference at a large number of patients, but we cannot dive so deep into different categories of clinical outcomes. And we look here at a real-world comparison of drug survival for first-line biologic agents. So drug survival means that the patients stay on the drug. And you see this here very clearly in the overall in the upper left quadrant. And you see here the infliximab, lowest line. Then you see the middle line is adalimumab, his top line is vedolizumab. And you see very clearly that there's a big difference in obviously overall adherence. The number of non-responders over time is highest with adalimumab, as you see here. It's about equal with vedolizumab and infliximab. And the adverse effects, you see very clearly that vedolizumab outperforms the anti-TNFs. Next slide, please. This is another study looking at propensity score matching and comparing ustekinumab and vedolizumab. And we have here 2 time points, so week 26 and the week 52, also both in Crohn's disease, and we look at clinical response, clinical remission, steroid-free remission. And I think it's very important to see that there is no performance difference between ustekinumab and vedolizumab. Again, I think making very clear that vedolizumab is a powerful agent in Crohn's disease. And this was driven even further. In the next slide, also looking at the real world, we now change from Crohn's disease into ulcerative colitis. Next slide, please. And here we see a real world multi-center comparison of effectiveness between tofacitinib and vedolizumab. And I think this is a very important one because I think we all have accepted and seen how powerful JAK antagonists can deliver, although, as we also have learned, there are some side effects on that road, especially for the more problematic patients. But you see very clearly, if we look at steroid-free remission, that patients when they're bio-naive or early in their career of having different biologics, that you have an equivalence between vedolizumab and tofacitinib. Tofacitinib is a trend to be better, but vedolizumab runs up to this. But if it comes to the very complex patients, very active, more than 3 biologics failure, then obviously you see tofacitinib has an advantage. And tofacitinib has also an advantage when it comes to endoscopic improvement, but not to mucosal healing. Here the 2 drugs are even up. We go back to Crohn's disease and ulcerative colitis. And next slide, please. We look again at a different cohort, and we go again at treatment persistence. And you see here the comparison between adalimumab and vedolizumab, treatment persistent on UC and treatment persistent in Crohn's disease. Left and right side, you see the big difference in treatment persistent UC, but you see also nominal advantage of the vedolizumab in treatment persistence in Crohn's disease. So I think by this time, I think you can share, hopefully, my opinion that vedolizumab is indeed a good agent, as good as the other biologics for Crohn's disease, and that there is a particular place for early use of vedolizumab, as we have also seen some real-world data, and as you know from the clinical trials, vedolizumab has a particular good side effect profile, especially no immunosuppression if you look at the infectious disease risk in IBD. Next slide, please. Now we come to the real-world data of the VEDO IBD study. Next slide, please. The VEDO IBD study has been running over 3 years, from 2017 to 2020. 1,226 patients with IBD were included. It's a prospective study from 40 centers, but prospective observatory. This means we cannot really say anything about scheduled endoscopies because that was not allowed in this study. It should be just an observatory trial, not a drug trial. And you see that 569 patients were starting a new vedolizumab therapy with or without prior biologic exposure, and 312 of these 569 patients are bio-naive. Next slide, please, shows you this flow of the study in ulcerative colitis. 512 patients had ulcerative colitis. You see that the split here of bio-naive patients, 314. You do have then obviously bio-naive patients who receive Vedo and receive also anti-TNF in the study. And then the next slide shows you the same slide of information for the Crohn's disease cohort, which is about equal size, 557 patients, out of which 327 are bio-naive, again splitting up in the use of Vedo and anti-TNF. You see already something very interesting. Remember, this is an observatory trial. This means we are not randomizing the patients. When you looked at the UC cohort in the slide before, you have seen that more patients were receiving Vedo by choice of doctors than anti-TNF. Because we do not have yet a comparison head-to-head study like Varsity in the Crohn's disease, German doctors also have a trend to use more anti-TNF than vedolizumab in Crohn's disease. We'll see the results in a second, but it's very important to see that doctor's choice, how they are doing it, because part of that real-world experience is a non-randomized experience. So we talk about drugs, we talk not about benchmarking, we talk about their use in a particular context of medicine and the relative success.
Stephen, we lost you for a brief moment.
Yeah.
Yeah, the chart is flow chart of patient with CD. You're just finishing that slide when we lost you.
Okay, then we go for the next slide now. And I explained that what we do here is not really a randomization. It's an observatory trial. This means the doctors choose what they want to do. In ulcerative colitis, German doctors choose more use of vedolizumab than anti-TNF in their patients. Now here in Crohn's disease, we see that they more often choose anti-TNF than they choose vedolizumab. So when we look at that kind of data, it's always integration between efficacy of a drug and the use pattern of doctors in a particular context. That's important to know when we want to interpret the data. So it's doctor's choice and then the result of the drug. Next slide, please. I think I've lost again, huh?
Slides come on now, baseline characteristic.
Okay, but you heard me, right? You were listening. Yeah, perfect. Okay. The baseline characteristics therefore show differences because doctors make choices. And you see, for example, age difference. You see that the anti-TNF patients were younger, 36 years, than the vedolizumab patients, 52 years, because doctors choose pro-vedolizumab because of the safety aspects in some of the patients. So that is a disadvantage also for vedolizumab. Then you see the disease duration is much longer corresponding to this in vedolizumab than with anti-TNF. 10 years versus 3.9 years. You also see that the perianal disease is more frequent in the anti-TNF group. You see the comorbidities are more frequent with vedolizumab because of the side effect profile again. You see that the age is higher also in the UC group with the vedolizumab. And you see also disease duration, same effects also as you see as in Crohn's disease. So by and large, this means vedolizumab is disadvantaged because choosing these patients, these more complicated patients, means that you really have a problem in efficacy here. So the way out of this is so-called propensity score matching. So this means the patients are aligned according to the baseline characteristics before they're compared. That has been done in this study. And we go for the next slide, please. Here look at effectiveness, conduction, UC, and Crohn's disease in this prospective real-world setting, trying to align patients. But remember, the patients showed a severe disadvantage for the vedolizumab because these were the older, the longer disease duration patients, the more critical patients. But still, you see that vedolizumab and anti-TNF performs about similarly well in ulcerative colitis. In Crohn's disease, due to patient choice, there's a very small advantage also of the anti-TNF over vedolizumab, but you will see in a minute what this means. Next slide, please. If you look at the partial Mayo score over time, that's in the next slide, slide number 22, please. Slide 22. Next slide. Here we see the partial Mayo score over 12 months in Crohn's disease. And we see really that the agents are similarly fast in the real world. There is no advantage in the speed of response for the anti-TNF therapy. And if we now dive deeper into the ulcerative colitis, then we see the next slide, please, which shows us the percentage of vedolizumab anti-TNF adherence. And you see very clearly that the doctors have a much higher adherence to vedolizumab than anti-TNF. After 1 year observation time, there's still almost 90% of the vedolizumab patients being on the drug, and with anti-TNF, it's just below 60%. So we now start looking at the week 52 data, patients with UC, and we look at the clinical response rate at week 52. We see a difference between vedolizumab and anti-TNF for clinical response, clinical remission, and steroid-free remission. You see a very clear advantage of more vedolizumab patients showing this success, especially in clinical response. It's an odds ratio of 2.39 in the favor of vedolizumab. And can we see this early? Let's look at the next slide. The next slide looks at the week 14 responders. And if we just take the week 14 responders and ask ourselves, is an early response at week 14 a strong predictor for vedolizumab success? You see, yes, it is, because the difference widens even. If you're a responder at week 14, you do better with adalimumab, and you do better with anti-TNF, and you do also better with vedolizumab. So week 14 response is a very good prognostic sign, but it's a stronger prognostic sign for the vedolizumab than for the anti-TNF because there's an advantage of vedolizumab over anti-TNF. Next slide goes away from the disease burden and looks into quality of life. We look at EQ5D visual analog scale over 12 months. And you see here the difference that vedolizumab is obviously having a large gain through this. Anti-TNF also has a gain. The difference between vedolizumab and anti-TNF here is not significant. Now let's look at the Vedo IBD study in Crohn's disease. Next slide, please. And these are the Crohn's disease population. Initially, you see this nominal advantage of anti-TNF over vedolizumab, the overall population. But remember, there were over 4 anti-TNF patients chosen. Over 1 vedolizumab patient, you had this big gap in age and complication because the more complicated and the older patient, the longer disease duration, they all got vedolizumab comparison to anti-TNF. Next slide, please, shows you the Harvey-Bradshaw index over time. Again, a similar speed of onset for both drugs. And the next slide again shows us adherence. And we're looking now at adherence, so the drug being still given at 3 groups. We see on top the vedolizumab group, and then we see very similar the adalimumab and infliximab groups. And here already see that something must happen because the adherence to vedolizumab and the prescription, the ongoing prescription of vedolizumab is much higher. It's above 90% than for anti-TNF, where it's just below 80%. And we can run the same analysis here and look at the big 52 successes here. If we start doing that in clinical remission, clinical response, clinical remission, and we start to look at anti-TNF and vedolizumab, and we compare adalimumab and vedolizumab and infliximab adalimumab. So we split this up. Let's first start with the aggregated anti-TNF, 63% against 76%. So another nominal advantage of vedolizumab. And then if we go down and split adalimumab and infliximab, we see that there's also a large level of differentiation for both anti-TNFs. If we again start to look at the a comparison. We look at vedolizumab versus anti-TNF. Next slide. Next slide. Yeah, here we make a comparison. We look at anti-TNF versus vedolizumab. You see that this is borderline significant here, touches the line. You see vedolizumab against adalimumab is not as strong, but a strong and positive performance of vedolizumab over infliximab. So let me conclude. Vedolizumab is superior to anti-TNF in several observations if used early. We have seen that, the first biologic therapy. Vedolizumab is always among the effective drugs in meta-analysis in CD and UC, ranking various. I didn't show this data because of time. Vedolizumab is least as efficacious as ustekinumab and anti-TNF in retrospective observational cohorts. You've seen even some advantage to tofacitinib in the more than 3 biofailure patients. And Vedo IBD is a large prospective observational multicenter cohort and demonstrates vedolizumab is at least as efficacious as anti-TNF in UC. And vedolizumab is more efficacious than anti-TNF in Crohn's disease if you start to look at either the early population or the early responders. So thank you very much.
Thank you, Stephen, for that. Now open for questions. We have a number of experts here who like to interact with you.
Yeah, I apologize that I cannot be with you in India.
I think you can see it on your.
Yeah, I see you, but
Yeah,
being there will be better. Obviously, I believe in the power of physical interaction with good colleagues. And the Indian doctors, excellent clinicians.
Thank you.
Stephen, excellent talk. This is Rupa.
Hi, Rupa.
Yes. So I had a very simple question. You said people were sticking on to vedolizumab for a longer time than the anti-TNFs. Now, what is the loss of response rate with vedolizumab? We know with infliximab, there are a certain percentage at 1 year and at 2 years.
In most cohorts, about 10 to 15% after 1 year. And then, as you know, the curve flattens. It also flattens for the anti-TNF. But with anti-TNF, it goes down 40 to 50% over the time. So I think my impression is that vedolizumab is probably more modern antibody. So it generates much less anti-vedolizumab antibodies. And several studies have shown this now. Obviously, the highest amount of immunogenicity is through the infliximab. If you look at the PANS study, followed by adalimumab, and then much less for the newer antibodies like vedolizumab or ustekinumab. And you should know also, Rupa, that vedolizumab initially in the very early drug development phase had problems. And the whole phase 2-3 program was repeated with a new antibody because it was brought back to shop and done with the newest molecular technology. We really did immunogenic after the first round. They had some problems. The first New England Journal paper was with a compound that's not today's vedolizumab, but they had a lot of antibodies.
Yeah, Dr. Jayanti here. Why is this drug not being used as a first line of treatment in
That's
both
exactly
ulcerative colitis and Crohn's?
In Crohn's disease, ulcerative colitis, I think it is a first-line treatment in Germany. In Germany, I think you've seen it also in the choice of the doctors. They did about 60% vedolizumab in their patients' first line. And the reason is very clear. It's varsity. It is the advantage shown in a head-to-head trial. Now, the problem, obviously, which you have in Crohn's disease, I think.
Can you hear us now?
I hear you. Yep. Now.
Sure, you had a question.
Hello, thanks for a wonderful lecture. This is Usha here from Puducherry. So the question I have for you is, do you combine vedolizumab with azathioprine like the way we used to combine, or it's just vedo alone?
No, I personally, first of all, there's no data to show any advantage. The indirect data which is out there is patients with and without azathioprine entering the trial. These were in the outside US centers frozen, and they were left on azathioprine stable. And there's no advantage by the azathioprine either in comparison to those who did not go in with azathioprine or in comparison to the US where azathioprine was even stopped. So I think there's no advantage to this, nothing shown. And then the second point is, how do we think azathioprine works? You've seen the 2 negative papers on azathioprine monotherapy in early Crohn's disease from France and from Spain some years ago. So probably azathioprine has only the activity of helping us to protect against immunogenic substances, against antibodies to infliximab or adalimumab. There, I think it works. And the PANS study has also shown that. But with vedolizumab having very low antigenicity, probably there's no need for that.
Right. This is Dr. Ajit Sood. Very nice talk. I totally agree with you that Vedo is a very effective drug, and for both induction and maintenance for UC as well as Crohn's. Talking about ulcerative colitis first, I mean, for patients with moderate to severe ulcerative colitis, this is one of the legitimate first choices along with the infliximab. And more so, it's important in a country like India where tuberculosis is an issue with anti-TNF agents. The risk of opportunistic infections is not as much as with Vedo as compared to anti-TNF agents. And the ease of administration, I'm sure that in coming years, with the subcutaneous Vedo being likely to be available, there may be ease of administration as well. I just want to, put forward some of the points regarding Crohn's also, that we have had a good data on efficacy of Vedo in Crohn's, but this basic mainly in the inflammatory Crohn's. It's not for the fistulizing disease where the response rate with Vedo is not as good as with the anti-TNF, mainly with the infliximab. But all said and done, we can't go away from the fact that Vedo is a very, very important drug. But I want to raise this issue here, that the bottleneck or the limiting step in the use of Vedo in India is the high cost. So that's one of the important issues, because most of the patients, they are not insured. I want to put one question for you, Stephen, that with the selective anti-integrins coming up, etrolizumab and other drugs, what is your postulation? Do you think that they're likely to be more effective than Vedo?
You've seen that vedolizumab is highly effective already, and it is already selective because alpha-4 beta-7. Now, etrolizumab is a bit broader. It's alpha-4 beta-7 and alpha-4 beta-E. so also a complex with E-cateterin. And the etrolizumab has failed. The phase 3 program is not as positive as it's needed for approval. So after etrolizumab, I don't think there's any more alpha-4 beta-7 biologics at the moment in development. There was one from Amgen, but this was stopped because they thought they're too late. When etrolizumab comes to the market, they will be too late. But now, they stopped too early. Now there's a couple oral drugs out. There's peptides from Prevention Bio, and these have just seen a phase 2 with an ambiguous signal. And then there is from Morphic and from Japan, from Eisai Ajinomoto, there are chemical substances out that are also alpha-4 beta-7, that's Morphic, or that are just alpha-4 specific, that's the Ajinomoto Eisai collaboration. And these oral drugs still have to show, I think, their efficacy. So at the moment, I don't think they're prime time yet. But it could very well be that one day we see an oral alpha-4 beta-7 inhibitor that allows us to do better maintenance, easier maintenance, and cheaper maintenance with our patients.
You showed data comparing Vido with the TOFA. Now, after use of even one drug, anti-TNF, I mean, this is a bit of, handicap for Vido that after exposure to anti-TNF, the efficacy is not as much as it's in anti-TNF naive patients.
But the same problem for all of the biologics. If you have years of anti-TNF.
So I'm saying that Vido is no doubt about the efficacy of Vido, but in anti-TNF exposed, even one biologic exposed patients, the Vido doesn't do as good as it does in anti-TNF naive patients. There, I think the choice is more tilted towards tofacitinib nowadays.
Yeah, you could discuss this. Certainly, say the choice between anti-TNF and Vido is about equal up in these later patients. You can discuss whether you want to take a JAK inhibitor, indeed, when you have already bio-failure, because the JAK inhibitors are very strong with this. With a JAK inhibitor, you have to observe a little bit the side effect profile. You've heard that we had a lot of discussions in the so-called drug procedure in the last months with our approving agencies, the European agency. And they will restrict the label and those patients having cardiovascular risks, being older and being smokers. So I think, and having had risk of deep vein thrombosis before. So I think that takes some patients out, but also highlights to you that using a JAK inhibitor is not without any danger, although it's an oral agent. So the side effect profile of vedolizumab is certainly much better than for the JAK inhibitors.
Yes, thank you.
I'm Dr. Prasad here. Thanks for the lucid talk. I have been with Vido for almost more than 12 to 14 years on the Gemini. And I find my patients could tolerate it well. And they both, in UC, they went into remission, deep remission also. So that way I was very happy. But you're a molecular expert. I just was wondering why in complex Crohn's, like penetrating Crohn's, like fistulizing Crohn's, why Vido is not that effective? That's the first question. The second question is, if, anti-TNF exposed patient, like you start on Vido, why is it that you don't get good response on a molecular mechanism?
The second question, I forgot the second part.
Second question.
If you could repeat, because I don't hear that well.
Professor Schreiber, he wants to ask whether why it does not work in anti-TNF exposed. Do you have
That's
some?
the other way, yes.
Yeah.
As I already said, it's, I think, general damage, which is probably not so well attacked by vedolizumab. But also anti-TNF doesn't change that. Well, but once you have the general damage and the destruction, probably the influx of new inflammation cells is not so important like an early disease. And that's also a question about the fistulating disease. Yeah, of course, you have the most powerful agents, anti-TNF, but then in fistulating disease, I think vedolizumab also works as long as you have also inflamed intestine around. Now, with anti-TNF, infliximab only, actually, you can work even in fistulating disease without inflammation in the bowel, and you will see some rate of success, but it's not very high.
If I could just join in the discussion here, I mean, it's said that people who are anti-TNF failures, I mean, there's a kind of upregulation of certain cytokines like IL-23 and IL-23R, and there's expansion of T9, T17 and Th1. I mean, that's a situation which makes it more prone to anti-interleukins. I mean, this ustekinumab rather than vedolizumab. So this is just a postulation. This is just a postulation.
I think it's completely right. I think you're a very good observer of scientific theories. I think the IL-23 expression, which you see, could be also just basically another marker of untackled inflammation in general. So it doesn't even need to be specific. But there is anti-IL-23, there's IL-23 expression. But if we take that seriously, my feeling is that will be field for the future IL-23 specific inhibitors. So 12-23 is a mixture of both.
Yeah, it's basically the 23 part. And same for fistulating.
It's the 23 part which is specific. And I think it's always better to have the specific IL-23 part addressed and not in connection with IL-12. You see these data coming especially strong for the dermatology, that probably the IL-23 blockade is even more powerful.
I'm timing in fistulizing. So in fistulizing Crohn's, the kind of T cells which are there in the fistula, I mean, they're not responsive to vedo.
I'm not sure that the T cells at all, because I think in the fistula you have more general problem of inflammation load and probably inflammatory tissue further up that is calmed down, and then the inflammation is less productive, or these fistula is less productive. I don't think that you really have something that works against T cells in fistula. For me, fistula are a mechanical problem that result from a weakened bowel wall at a pressure situation, which is the reason why they form so often at the terminal ileum or on the rectum, the perianal region, because these are the valves, the stops where the pressure builds up. And once you have a fistula, I think we all know that it's very difficult to heal that situation. Probably the only way how that works is calming down inflammation and then intense surgical debridement, where you take the epithelium out. And that has been shown, I think, with the stem cell therapy, alloficel. Already that mechanical procedure cleans a lot of the environment and helps fistula to heal. And then you can also use these adipocyte-developed stem cells that are sold as alloficel, davasfocel, as a generic name. So, but I think with vedolizumab, you can also get the patient inflammation-free. That must be your game. And when the patient inflammation-free, subject the patient to proper surgical therapy. Now, in the choice of drugs, it's very clear with an own label for fistulating disease, infliximab goes before vedolizumab. But if you have a choice which is determined by, say, for example, concerns of safety or other concerns that would drive vedolizumab, my personal experience with vedolizumab is also very good.
Thank you, Stephen. I think this was a fantastic lecture and discussion. We have come to the end of this session, and on behalf of the AIG, I'd like to thank you very much for being here this evening with us. I think we'll quickly move to the panel discussion. I request Dr. Rupa to start the program.
Okay, then thank you very much, and bye-bye from Germany, and I hope to see you sometime again in India. Thank you.
So I think after an exhaustive discussion, this is going to be a case-based discussion, and it is going to be something which we face day in and day out. So I think how will we position? We discussed the science behind it, and now we'll just discuss what happens in real life. So I'll just invite our esteemed panelists for the discussion. Dr. Randhir Sood, sir, can you please? Dr. Ajit Sood with double OD. Dr. Shobna Bhatia. And Dr. Devender Desai is on the Zoom, and he's on his way to this place. So he might join in any time. His flight was delayed by more than an hour. So he's on the way, and he will join us. So treatment today has progressed, and it is actually the era of biologics, and we are spoilt for choice. We have infliximab, adalimumab, we have vedolizumab, ustekinumab is going to come soon, and we have these small things who are not that small, the tofacitinib, which is attracting headlines as well. In the situation, what do? We know biologic use in India is increasing. Dr. Desai has kindly shared this slide. But what we are finding is in 2% in the IBD task force that was done in 2012 as to how many people were how many percentage of patients were using. Right now it is ranging from 15 to 17% in various Indian studies. For us also, we find that there are 15% on biologics, but 77% stop biologics by 2 years maximum. So in the situation, one size does not fit all, and all of us will agree that when we are choosing, there are numerous ground factors on which we are doing it. And choosing the best therapy when there are so many choices needs a crowd like this. So we have the panelists, but we'll take in opinion from everyone. Balance between efficacy, safety, and cost. So what are we going to discuss today? What is the first line biologic? Which to switch to? What is the second line biologic that we will prefer or should prefer? When can we stop, and can we stop? That is another question which is very relevant to our country, our situation. What about the small molecules and specific situations with specific choices? So the case is very simple. What we see in day-to-day practice, a 20-year-old young student studying law in Delhi, ulcerative colitis, pancolitis, not controlled on oral and topical 5-ASA. Needed 3 courses of corticosteroids in the last 1.5 years. Current colonoscopy is showing a Mayo 2 or a UCIS 4/8 kind of. Now, the next question is, what will be your next line of management and why? Dr. Sood, your mic.
I think we'll have to remember it's a law student who you're
Yeah,
going
yeah.
to treat with biologic.
That's
think
what I
that's a warning
noted,
to run
yeah.
this.
So, logically, as a first line, with the second line, we would have introduced immunomodulators because of the cost. The only issue is that his age and how long are we going to continue? Are we going to take the risk of subsequent, malignancies? So that's the issue, but we can decide on the duration later on in course. I will, at present, if affordability is an issue, I'll not jump onto biologics immediately. I'll go to immunomodulators.
But he has taken, I mean, it's kind of a, it's showing signs of at least steroid dependency, if not. And there are so many studies now on the negatives of azathioprine monotherapy. So if money were not a factor, would you?
Yeah, then of course, choice will be between either anti-TNF or anti-integrin. Now, it's a young person, even if of the anti-TNF, the first choice will be infliximab. With infliximab, again, you will have to either give monotherapy with infliximab with the risk of developing antibodies or a combination with azathioprine. So that's one option. The second option, after listening to Stephen now, is Vido. But the risk profile of this patient, considering that he's healthy, he doesn't have any associated disease, I think infliximab will be my first choice.
What about you, Dr. Sood?
Why not
Right.
azathioprine?
Rupa, you said that you given us the picture, endo-meo picture, meo-endo picture, you said 4 out of 8. And what is the overall severity of the disease?
It is extensive pancolitis.
No extensive. I mean, what is the total Mayo score? I mean, we have to see whether it's
Mayo,
mild.
Mayo 2, grade 2.
No, overall Mayo score will be high because 2 score will be only from the endoscopic
Yeah, so
score.
it is, I would just label this as a case which is
Moderately severe.
Yeah, it's moderate to severe.
So 6
it's
to
not
9.
exactly, yes.
6 to 9.
Yes,
So
yes.
if it is a moderately severe, if he's already taken steroids, and I hope he was not on
No,
thiopurine
I'll come to the story later.
Okay,
I
okay.
wanted to hear from you what you would have done if you just knew this much.
If he is he's a moderately severe disease, and he's a young person, he's taken 3 courses of steroids in a year. So if we add azathioprine, it's not going to cover up right away.
Yes.
So we need something more for induction of therapy. For induction, I think the choices are between anti-TNF, anti-integrins, and even JAK inhibitors. So we have to choose among the 3 groups.
Yeah, because what happens is when a patient is often coming, they already have come with this history that I've used steroids for so many times and they're looking for a quick relief also. So I think, yes, we have to consider. And at this stage, what I wanted to ask was, Dr. Shobna or anybody else from the audience, what is the role of risk stratification in the Indian context? Because we discussed, okay, he needs it, but like between the using azathioprine, convincing him to wait for, steroid and see whether it can be handled, should we bring in the thing of whether there is a risk stratification or not? Dr. Shobna.
So Rupa, whether it is ulcerative colitis or any other thing, I think the role of risk stratification for any treatment remains. We have to find out what is his risk of getting worse with whatever treatment he is getting, and what is the best treatment for him today. In the acute setting in a moderate to severe colitis, where the patient has not already responded to steroids, I would first just go back into clinical situations and find out whether he was compliant to previous therapy, whether he had any other superinfections like CMV, and tackle those before I jump in and say I will now use either an immunomodulator, but of course immunomodulator is going to take time to act, as Dr. Sood just pointed out. And once all that is ruled out, our choice is going in for a biologic drug. And with these, the risks we'll have to see is at a 22-year-old, if he does not have any comorbidities, does not have any risk of infections, and does not have previous exposure to tuberculosis, I would say infliximab would still be the first drug. It's the fastest acting.
Yes, sir. Yes, sir.
Now, in this patient, going back, after the first
Your
dose
audio, sir.
sir,
Yes.
after the first dose of steroids, first course of steroids, if this patient had another relapse, I think we should have started on azathioprine at that time. That would have been my first choice. But unfortunately, the patient came to you with the three courses of steroids, and that time adding a azathioprine will not help us much. At this stage, we have to start on biologics.
But
here,
I'm sorry.
The patient will not come back
But
to you.
why do we say once the patient, even if the patient comes on the third course of steroids, patient has achieved remission on the third course of steroids, what is the data to show that azathioprine will not work in this at this stage?
No, at this stage, if you want to try azathioprine alone cannot induce remission in this patient. At this
No, I'm not
stage.
saying inducing.
You have to start steroids again. Yes. Again, you start steroids. That is another option. We can actually think about that.
So,
But you look at this patient. This patient has got an extensive disease. He has got extensive colitis. That's what I understand. No, so this is a high-risk patient who is likely to have problems in the future. But of course, there is an option if there is a financial constraint. I think the option of starting giving one more course of steroids with azathioprine. But I tell you, giving more and more courses of steroids in young patients, it may not be a good option. But now we have actually biologics who are actually cheaper and good also. We have got oral biologics and it's cheap, and then we can actually think about that.
No, but then here you are advocating oral biologicals. Basically, you're talking about JAK inhibitors. You're basically talking about in a naive patient, which is not an approved indication, is it? Am I right?
No, what I'm telling is
can I intervene? Just one question. It's not maybe, I'm sorry, I'm just... Ajit, you are a huge user of azathioprine. You have much published data on azathioprine. My question is in a different context. I also use azathioprine quite a lot, but in a young patient, I'm always at the back of my mind that if I put them on azathioprine, patient respond well, how long will I give it? I mean, in a young patient, it becomes a major problem to stop them or to change over. So my objection, I raise an objection to use of azathioprine.
In fact, here I would like to put in a point that, in fact, for the pediatric age group, the global pediatric consensus, they are advocating that they should not use azathioprine at less than 16 years of age, and it may be worthwhile to use methotrexate because of the increased risk of lymphoma in the long run. So the only issue is, and I think too soon, sir, yeah, both of you. I mean, so we use a much lesser dose than what is advocated, and we find that in India, a much lesser dose works. So what would you think, sir, that should we, because we are sometimes, or should we not use in the age group, as he's mentioning, the risks of lymphoma and how long we should use?
Yes, I agree with Philip that steroids, when we were using steroids, we should have added azathioprine, but in this case, that didn't happen. Now, it's a very relevant question what Dr. Ajay has raised, that what is the risk of lymphoma in patients on long-term azathioprine? Dr. Ajay, it has been now documented that the risk of lymphoma on azathioprine has been more highlighted, and the risk is not as much as it has been reported in the earlier studies. Vineet has reported this. We have also analyzed the data. We tried to publish it, but it didn't get through. Only suggestion is that when we are putting a young patient on azathioprine, we should get EBV virus. Patients who are not exposed to EBV virus, we should avoid because they can get acute EBV virus, which has risk of lymphoma again. So the lymphomas in patients on azathioprine are more related to EBV virus. So I will say that azathioprine has a role in young patients. On the contrary, had this patient been 65 or elderly patient, then we couldn't have considered azathioprine.
I think...
Rupa, one more point. I mean, there is a plus point for azathioprine or 6-MP, whatever you wish. Because even if you are considering adding a biological at a later stage, then you've covered the immunosuppression. Start a biologic now and then you start, don't want to give Imuran right now. Then you are, success trial has clearly showed that the benefit of combination of Remicade and azathioprine is far better than either of the two drugs alone. So there is every reason to start, whether it's late or not too late. I think the azathioprine has to be added in this patient. And most of us, I think,
On just a
the
small
risk of Imuran is, in general practice, my opinion is that it is more with the hematological toxicity, which you can discontinue the drug.
Yeah, I think
I think hardly those who are leading the practice of the IBD only they may be using, but in their day-to-day life, everybody is using the azathioprine along with
No,
the
we
steroids.
also use azathioprine as
Yes,
a first
everybody
drug.
is using.
It's not that we are not using.
I use azathioprine very commonly, but I just want to, since methotrexate is brought in, I thought I'll just make my experience. What I'm telling is now, in ulcerative colitis, I think generally methotrexate is not very commonly used, and it's not good for induction, but there are studies that probably that will help in maintaining remission. But I still believe none of my patient is on methotrexate or ulcerative colitis, but Crohn's disease, yes, there are many patients on methotrexate. But I tell you, generally if you discuss the patient about the possibility of methotrexate, weekly injections, and telling about, they read about the complications, etc. And in young females, we are very reluctant to give. So there is only a select population where methotrexate can be given. But still, most of the people, I believe, are happy with azathioprine rather than with the
I think I would also like to add, Rupaji. This patient was steroid responsive. 3 courses given earlier. It was so. What I would do if the patient cannot afford, I would start an azathioprine, put on 12 weeks tapering course of
out of the
steroid.
question, because if the patient cannot afford anything, then we can't do anything.
No, it's wrong statement. Mohan Prasad, all of Mohan Prasad's patients can afford biologicals.
Oh. No.
One more thing is,
I think Mohan Prasad is bang on. In fact, I was also going to raise this point, because here you have a patient who has not probably received the ideal treatment that one should receive.
Correct.
And azathioprine, according to me, is a much maligned drug. I think it's not all that bad. I think we should be imposing faith in azathioprine. The profile of patients that Dr. Shobna referred to, young, no history of infection, no risk of infection. I think if steroids and azathioprine fails, I think with the data that was projected by Dr. Stefan, I'm tempted to think that we should actually be going in for JAK inhibitors
I think
as
we'll come
an
to that
alternative.
when we are positioning.
Yeah.
But right now, I think we know that in India we are using azathioprine. We know that it does work. We published, Dr. Sood has published that it works at much lesser doses, and it's not that bad. But for the patient, we also need to understand what will be best for him in the long term. So I think what we need to do is risk stratification at the very beginning. So you have to, when you first see a patient, decide whether they are low risk or a high risk patient. So this we are talking ulcerative colitis, but we might have Crohn's disease, we might have extensive small bowel Crohn's disease, where I think when a biologic is available and we wait for years on azathioprine with kind of partial response, that may not be worthwhile and we may have other complications. So I think some sort of, a low risk versus high risk for ulcerative colitis and Crohn's disease, and we should discuss with the patient maybe, I think Dr. Randhir.
Rupa, when you're talking of the risk stratification, I have got 3 issues. First is the risk of the disease per se, which you're putting up here. That is according to the parameters you have already elaborated. The second is the risk of the patient profile independent of the disease. Like in this patient, 20 years old, we talked of JAK inhibitors. we don't know after 2 years what does happen to the patient with JAK inhibitors and their overall toxic, infection rates, overall toxicity rates, so what is there, and compliance to JAK inhibitors, what happens, because the data is only very short for IBD with JAK inhibitors, only since 2018. So the third is, of course, the upcoming strategies of treatment which are in the pipeline. So we have to keep in mind, today you have got a huge population of, the anti-biologic exposed, making them less responsive to the new therapies.
Yes.
So whether we should be looking at long-term, because he has the entire lifetime to be treated. So I think our decision has to be according to these three strategies, not only according to his present status of disease.
Yeah, a little long-term planning. Yes, sir.
Just one thing is that I think we should not confuse severity and risk.
Activity.
Severity is what is this thing at this present time, and that needs to be addressed appropriately. High risk is a different dimension that needs to be also taken care of. So tell us what is the severity of the disease, and then we can look at the risks.
Yeah, so severity of the disease, as I said, it's moderate to severe ulcerative colitis, but the point is well taken. I think there's a difference, and we'll come to that later, between activity of the disease and severity of the disease. Activity is what is it now, and severity is a little longer term issue.
Rupa, there's one more thing. Rupa, since this is ulcerative colitis we are discussing, we also need to figure out whether this patient has any other extra-intestinal manifestations before we decide the choice of the drug for them.
Yeah, so this patient, of course, did not have anything additional, no family history of IBD, non-smoker, and otherwise all okay. So I think the issue is that risk stratification, we are now evolving from reactive to proactive disease management. So earlier we used to wait for patients to get more symptomatic or show signs and then initiate a treatment. Now with biomarkers and other things, I think we have to get more proactive so that complications do not develop. And ultimately, as we have just discussed, patients with IBD have varying disease courses, and this limits over or under treatment. And I think this just sums it, that we do not want to undertreat. At the same time, we do not want over treatment as well, because we have to plan for the next 100 years for a 10-year-old and vice versa. So for our patient, actually, 22-year young student studying law, what will be your first choice biologic? So
Rupa, one more issue I want to raise here. See, we're all talking about long-term treatment in a 20-year-old guy. We know that we can never conquer the disease. It's going to go on forever until we find some solution for that. So even if we use a biologic, how long our Indian patients stick on to biologics? How
we
much
are going
can
to
they
come
afford?
to that, sir. Once we progress, we'll come to that part also about exit strategy and
So
when can we stop.
what we do clinically is now to induce remission, and then probably take them slowly off the biologic and maintain on mesalamine. That's what we do in clinical practice. It may not be the right thing to do. I'm not saying that's the right thing. But for
So
an
I think
Indian patient, how do you continue?
I think Dr. Desai, thank you. You finally arrived. So I just wanted to ask you if you are ready for the first question. So what will be your first choice biologic? And we'll just take a hands up for that. How many after your comments?
So at the moment, infliximab. And
After Schreiber's talk? After Professor Schreiber's talk?
No, so basically, in ulcerative colitis, I am not aware about clinical decision tools. Like in Crohn's disease, we have clinical decision tool for vedolizumab. And if the score is more than 19, then that means that patient will respond better to vedolizumab. So I'm not aware about any tool like that to select infliximab or vedolizumab. Obviously, when you say that elderly patient with previous tuberculosis, and patient with previous malignancy, one would prefer vedolizumab or infliximab. But in this patient, my first choice would be infliximab.
Dr. Shobna?
I think I said that in the first time also. that my first choice in this patient would be infliximab because we want to induce remission. And it is
So
probably
is it
faster than
infliximab
any
for
other.
everybody, if I have a show of hands? First choice biologic?
No, I think I have a point to differ here. This patient hasn't received supervised therapy with 5-ASA, steroid and azathioprine. In a young patient, that is a time-tested therapy. That should be the first line. And if that fails, then patient should earn a biologic. He should not be just given a biologic.
This patient actually did receive oral and topical mesalamines and 3 courses of steroids, and I'll come to it. He actually used azathioprine very irregularly because he used to have headache in the hostel, so he used to stop and take, and that is his sketchy history when he came to us. So mesalamines, yes, he had used, and he was continuing to use even with the steroid.
In our unit, we use for UC, our response in patients with widow is good. So my choice would be widow. In this case.
You said that endomyo had gone to 6. If it is endomyo is 6 out of 8, that means very high possibility that until unless we act fast, he will need colectomy.
Yes.
So here we are looking for a drug which has a rapid action.
Fast, yes. So I think the issue here is that it's a young student, more restless, disease progressing in severity on multiple courses of steroids. And I think what to use first is we really don't know. We have to consider activity, how sick the patient is now, what Dr. Naresh was mentioning, and severity, which includes that kind of risk stratification and prognosis. There are no head-to-head trials. So we go by, efficacy, route of administration, availability, and of course, cost effectiveness. So when we bring in the small molecules, sometimes cost is the only factor, and that's the reason why we are discussing. And I just want to just brush past 2 slides, like comparing induction of response and remission. There are no head-to-head trials, but if you just compare all of them together, they are all relatively the same, both for induction of response or remission or even maintenance. So if you're thinking of absolute routine clinical practice,
no, but Rupa, I think we are now comparing apples with oranges. We are talking of this patient who has severe disease, and on one hand we say we need rapidity of action. If we want that, then we have comparative trials showing infliximab having advantage over other biologics
for acute severe colitis. Yes.
So one important point I just want to mention, you mentioned that the points which you take into consideration in deciding the therapy. My suggestion is we should add nutritional status also into the, and patient's choice. I mean, these 2 things should also be added, besides, of course, comorbidity and exposure to tuberculosis and infections. And nutritional status also is important, and patient's choice also we have to keep it in mind.
And finances also.
Patient's choice, that will cover the financial.
Are we discussing a case of acute severe?
No. It is not acute
it's moderately severe.
It is just that moderately severe, who we believe has not received the ideal treatment. Why not give a chance?
He's progressed from 4/8, 2 slides earlier, to 6/8 within this span of time. So he's progressing pretty fast.
So if you go to that bit of statistics which Rupa had mentioned or had shown in the last table, you find the response rates and remission rates are almost the same across the entire list, right up to the bottom. Now, my way of thinking is that we are here to look at statistics as they are, evidence as they are today, and also plus, of course, what was shown about half an hour back. In a patient who is not at risk for infection, why not give tofacitinib as a first choice? In a patient who is at risk for infection, Vido should be the first choice.
I think that answer already Dr. Sood, both the Dr. Soods had given. that tofacitinib for a young person, the risk of side effects, and second, it's a relatively new drug, so we don't know how it will pan out.
Yeah, my argument is, why are we ignoring that more than 10 years long history of use in our patients with rheumatological problems? I think there is a huge body of evidence for tofacitinib. So I think, and there is also some evidence now which is emerging that rapidity of action also there is an advantage, ease of administration there is an advantage, cost there is an advantage, so why not?
And as far as acute severe UC is concerned, there is no doubt it has to be infliximab, as Randirji was pointing out, not in this case.
We are dealing with moderately severe active ulcerative colitis. And your question was, which is the first choice biologics?
Yes.
Tofacitinib doesn't come in biologics. That's a small molecule. So, I mean, that's why we were focusing on...
That's a lawyer answering.
No.
That's a
drugs,
lawyer's answer.
the drugs which are to be considered are infliximab, adalimumab, vedolizumab, and golimumab. Out of these 4 drugs, now Versity trial has clearly shown this is the only head-to-head trial for moderately severe ulcerative colitis. Versity trial has clearly pitched in favor of Vedo over adalimumab. So we can't say that all are equal. Now the other...
I mean, do you want to rule out biosimilars or keep that as an option as well?
No, I mean biosimilars of course stand. I mean, biosimilars are we are talking of originators. These are the 4 biologics. So with Versity trial, convincingly showing going in favor of Vedo, we can't say. So my suggestion is that in a patient like him, infliximab and Vedo, both are the first choice, legitimate first choices. If we say, and golimumab is useful, adalimumab seems little inferior when we compare these 4 drugs which are available. Golimumab somehow has not come to our country, so we can't discuss it. So for a moderately severe disease, among biologics, these, I will put them like this. I mean, we can put infliximab and Vedo together. For rapidity of action, as we are saying, that if it is 6 out of 8 Mayo score, Endo-Mayo, it's very high score. So I will definitely choose infliximab over Vedo here. But
and what about his
Dr. Sood,
about
Mayo score is not 8. UCEIS is 8. Mayo is 12.
Sorry, 6 out of UCEIS.
Yeah, so I think we should be clear about that.
No, I stand corrected. It has to be Mayo 3. It's UCEIS.
Just to answer Dr. G.N. Ramesh's question, because I think everyone over here would like to know, would you use tofacitinib?
Dr. Rupert, just one. If you see, the response rate is just about 40%, across all the drugs. So what are the chances that this particular person is going to be in the 40% or is going to land up in the 60% as non-responsiveness? We keep talking only of the response, which is just about 40%. We never talk about the 60% who are not responding. So what is it that's making this difference when we introduce a drug which is supposed to be taken for 2 years or 4 years, and in a patient who's coming, named patient who's coming with moderately severe colitis, whether Crohn's or otherwise, what are the chances that he's going to be in the 40%?
I think this is a very good question, but so far what is available is some of the markers like P-ANCA positive,
so
ASCA
you can
positive.
just tell us what are the biomarkers you would like to consider before starting them on biological.
But the question I will look at like this, madam. Anyway, we are decided to start a biologics and we start them. We hope the patient should be in the 40%. But primary failures, secondary failures, everything we expect. So once the patient is not responding, then you switch over to that.
Consideration for taking the surgical consultation?
No.
So at 22
not at this stage, too premature.
Not at this stage.
But another point is, when we are comparing biologicals with one against other, we have to see that when we talk of superiority of one over the other, it is in the short term, 8 weeks data. Because there are certain biologicals that in infliximab we are giving dose, dose which is weight related, and we are giving IV. On the other hand, we are giving other biologicals as fixed dose, and so. When you look at the data which is more than 12 weeks old, then practically all the biologicals appear to be similar in efficacy. What do you say?
Just about the markers, genetic markers are available. Now, HLA-DQ A105 which is prevalent in European population, nearly 40%. We don't have data in our country. I mean, if a person is having mutation, DQA105 positive, there's a high possibility of developing antibodies to infliximab or the other anti-TNF agents. So that's a
Yeah,
small
I
group of
mentioned those
patients.
because it has been seen that response can be correlated. So I think surgery may be a little too early because he has just taken steroids, practically no other immunomodulators, and he's a young person. If it were acute severe ulcerative colitis, we would
He
have
has
still-
come to a gastroenterologist. Let us, let us, we also
And
mean
there are no
something.
surgeons
With the little
here.
of the knowledge, I think infliximab is the good drug. This is the thought process. I don't know much about the data, but
Yes, I think post-op complications, pouchitis, if they come back with, it's... Yes, Dr. Desai, your comments before we quickly go on actually, because we are
So-
standing between dinner and discussion.
So we are actually trying to choose between infliximab and vedolizumab and maybe tofacitinib for this patient. So also depends on the patient's choice and how easy a clinician can adjust the dosage of infliximab as well as monitor the response. So we know that for infliximab we have the therapeutic drug monitoring, which is not as well known for vedolizumab. So that one factor also we should consider when we are trying to choose the drug.
So I think this is what we have already discussed, so we'll just go past this. What about anti-integrins and vedolizumab as first line therapy? And this has been discussed right now with real-world data by Professor Schreiber. So just in short, maybe as first-line therapy, because primarily because of the safety issues. It's gut selective. There's a lower risk of tuberculosis. So sometimes when there are patients where you cannot really decide between tuberculosis and Crohn's disease, or there is a history of tuberculosis, you have treated for pulmonary tuberculosis, maybe for such cases it will be better for us to think in that line. Now, a quick answer from the panel. Any specific scenarios for first choice biologics? So we decided this patient is on infliximab, that is the first choice, but were there any other factors by which you would decide something else other than infliximab? What would that be?
I think you discussed that. Of course, the hot topic today remains where to position tofacitinib, because it is very effective. The onset of action is quick, cost and taken orally and cheap. So, like GN mentioned that that's one choice. You can decide how long to give it and shift over subsequently. So that's one. Rather, I would have gone the other way, that if you are choosing infliximab over others, then one factor will be perianal disease.
So I think one of them, Dr. Sood, you would like to comment?
Yes,
I mean, I've just put it up for...
Yeah, I think if we had to choose between infliximab and vedolizumab, the two other things which we have to keep it in mind is the age of the patient. Elderly person, more than 65, we go for vedo. Past history of tumors, again, we go in favor of vedo. And you mentioned a third point is tuberculosis. So exposure to tuberculosis, or if there is an issue with tuberculosis, we favor vedo. But points for infliximab are obviously rapidity of action and the severity of the disease. And we know that subcutaneous vedo is also now likely to be available soon.
So this is just for summary that yes, acute severe colitis, we think of infliximab. There are some few case reports coming for use of tofacitinib in acute severe colitis as well. We are still not there. And the others are, of course, the choice that we discussed. Now, I'd just like quickly to go to you, Dr. Shobna. What would you target to achieve once the patient is on biologics? Would you want clinical remission, endoscopic remission, complete muco? What is the target that you are looking for? Or just clinically patient is okay, we continue?
So no, so initially, of course, you want clinical remission. If the bleeding stops, the number of stools comes down, at least in the initial stage, I'm happy with that. Over the long term, I would want a complete histological
Would you
remission.
increase the dose of biologic if you find internally active disease despite the patient being in clinical remission?
No, if the patient is in clinical remission, I would accept that as the first target. Because the first target is to see that the patient is clinically relieved. If the patient's number of stools are coming down, the blood is not there in the stools, then I might go for things like fecal calprotectin and CRP to see if the patient is really in remission. Endoscopy you can't keep repeating because it's not the end point usually.
Ruba?
Yes.
Matthew here. Exactly, I'm coming to that. Suppose a patient is clinically in remission, then will you ask for the patient to undergo an endoscopy?
I'm asking the board.
So that's what we are saying.
Suppose a
We'll
patient
discuss tomorrow.
Philip, yes, it is our endpoint is no way
No,
symptomatic
I
remission.
agree.
Yeah, I mean,
Initial
Suppose you
endpoint.
want
No,
to,
no,
you want
no,
to know
no.
endoscopic remission,
It
you have
has
to
to
do a
be. It
colonoscopy.
has to be gradual. I mean,
Yes.
we have written this article that when to do
Yeah, I think
colonoscopy.
we have to do
If we discuss it today, then you will miss your dinner and your tomorrow's session will be cancelled. Tomorrow, then half day.
Yes.
So I think to cut the things short, I think we have to look beyond only clinical remission, and we have to interim check inside for if disease is active, then we actually at least up to endoscopic remission we should look at.
So I think
quick
Rupa-
comment from you, Dr. Shobna, before
So
we
what
go
I
to
said
the
is
safety
that
issues. with Dr.
initially, I'm looking, the target is that the patient should feel better. The initial target. So as Dr. Devendra just told me, the target keeps moving. So as you go along the course of the disease, your next target is endoscopic remission. Or at least we can try and do a fecal calprotectin and see if it's coming down. Next would be endoscopy, and over time, which may take 6 months to a year, is histological remission. And that would be my final target for ulcerative colitis.
Dr. Sood, a quick comment on the safety issues. How important is with Sood?
No, infliximab, I will say that once a patient is on infliximab, if a patient has fever and it's not because of active disease, and we rule out infections in the urine and other cellulitis kind of thing, we should be sure that tuberculosis is coming. And Vineet has shown convincingly that CT chest has a role in this. So I think tuberculosis remains an issue. Dr. Puri and we together have also reported a high prevalence, around 12%, and Vineet's data also shows a high prevalence of tuberculosis. This is an issue.
So I think we have safety issues with most of the biologics, even tofacitinib. There are non-melanoma skin cancers, lipid elevation. We don't know in the long term how much it will impact. But if you see and you put up a safety pyramid amongst the biologics, since the topic today is positioning biologics, you would feel that ustekinumab and vedolizumab are actually at the same level. And I like this. This is a paper from Miguel Riguera's paper, IBD Journal 2019, that we should also treat inadequate treatment as an adverse event. If we think of adverse events and don't treat the patient, that is actually a bigger adverse event. And this would be the kind of thing that we look at. Steroids have the highest risk. So how essential is therapeutic drug monitoring?
So just
and
before.
what to do if drug monitoring is not available? Quick answer from you, Dr. Desai. This is your forte.
So first, I would like to go to the last question. So we have 22% risk of adverse event and about 1.5 chances of lymphoma if we target what is practiced, what is advised, treat to target. So we have to take into account that into our situation also. Then the therapeutic drug monitoring, as we practice it, it is more reactive, but proactive. That means if the patient is in remission, that is required in patients who are high risk patients, like young patient, extensive disease, those who are visualizing disease. So those patients I would practice therapeutic drug monitoring definitely.
So where therapeutic drug monitoring is not available, uh, would you like to take it or Dr. Shobna? Quick answer. Dr. Sood?
If we don't have, for azathioprine, we can rely on the MCV. But for infliximab, we have to go by symptomatic remission, biomarker remission, and endoscopic remission.
Yes.
We put it like that, sequential. So that's fair enough.
I think that's in summary that we are, majority of us, when we don't have drug monitoring or therapeutic drug monitoring facilities available, we can go by biomarkers, cross-sectional imaging, and endoscopic and intestinal bowel ultrasound lately, which can be useful. Now we come quickly for this patient. He actually was okay for almost 3 years. Then he had UCIs 4/8, again a relapse. And what would you do next? So we know that to cut this thing short, that this patient had antibodies, the infliximab level was okay, but there were no antibodies, and we wanted to switch from infliximab. Now, what would be the next drug of choice? That is what we have to decide. So can we have a quick answer from you, Dr.
Now we have again the option of either putting him on TOFA because he's biological exposed at least once, or we can go to another anti-integrin now if he was on infliximab. So these are two options.
Anybody else with any other option?
I think we should look into the reason that why is there relapse.
Yes.
And I'm sure that everybody means that we have to rule out C. diff, we have to rule out CMV. We have to make sure that here is the role of TTMs. So if a patient is not responding, this is what is a reactive approach. Here we have to depend on TTMs and antibodies both. If we feel that the drug levels are okay, right, then or antibody is a more, if we have not put this patient on azathioprine earlier, we can easily add azathioprine in a smaller dose at this juncture also. So this is one way, because switching is not very easy.
Losing response and switching therapy is easy, but what are the situations where we will switch therapy for other reasons? So if there is a drug reaction, then we have to switch. If there are joint pains, we have to switch. History of cancer, we have to switch. Pregnancy, we have to choose what we can. And in the interest of time...
Pregnancy, we don't switch. Yeah, there's convincing
TOFA
evidence.
we stop.
No, this we are talking of infliximab.
Yes.
We don't switch. We don't stop any of the biologics.
Correct. I completely agree. But I'm just saying that...
and arthritis, somebody develops arthritis on infliximab, then it's an immune response to infliximab. Then we can add a second drug or we can withdraw infliximab.
So I think these are the thing. And if there is a history of cancer, then vedolizumab turns out to be the better drug. And we are seeing more and more such cases who have been operated earlier, have just finished chemo, and these kind of cases when they need it, then maybe vedolizumab will be the better choice.
Not anti-TNF exposed patients.
Not anti-TNF
Not the first
exposed.
choice. If you have to choose, no doubt about efficacy of Vido. But anti-TNF exposed patients, if you have to choose a drug, then the list is UST, TOFA, Vido is lower on the list.
Yeah, so I think this is the summary of it all, that if there is primary non-response, then you have to switch out of the drug class. Otherwise, you will have to do therapeutic drug monitoring and deciding. So we know what we have learned about anti-TNFs, the rapid onset of action, effective with complications, immunogenicity is a risk, but the best thing is that we know what its side effects are, and I think all of us have more experience with anti-TNFs. Of course, there is infection risk and lymphoma risk. Now comes the thing that long term, what are the options and can there be an exit strategy? We have discussed this, that anti-TNF naive patients do better with other classes of therapy. And for our patient, actually, that is what he wanted to ask. That you are telling me a second line biologic, but what if, when will I get out of it and which drug is better. So as Professor Schreiber said, that if you are not exposed to infliximab, if you are exposed to infliximab, all other biologics, including tofacitinib, the action is lesser. And tofacitinib, again, we have discussed, but the problem remains the same. So can biologics be discontinued? So I think quick comments from the panel on this before we wind up actually.
Most of the times the biologicals are discontinued by the patient, not by the physician, because because of certain financial reasons or inability to continue with the treatment because of logistics. But yes, I practice that if a patient is in deep remission or is has been symptom free for more than 2 years on biologicals, then we can discuss this with the patient and with a very clear understanding that there can be a comeback.
I agree with this that the question of de-escalation arises once there is a complete mucosal healing. Only then, that also a sustained healing. And now what to do? I mean, there is some literature now that which normally we don't say that when a patient goes on biologics, we generally discontinue 5-ASA. But here is a situation when we want to de-escalate. There may be a possibility that 5-ASAs, if we put them on 5-ASAs and continues on 5-ASA, or we withdraw infliximab and let them be on immunomodulators in the long run. This may decrease the chance of relapse. Right? This we are talking of UC.
Yes.
I mean, for Crohn's...
Dr. Sood, sorry to interrupt you. I think you can never discontinue 5-ASA in UC. That is the standard. 5-ASA is never discontinued.
If you are saying very strongly, I'm also saying equally strongly, there is a data that once the patient goes on biologics, I mean, there is a meta-analysis which says that 5-ASA has no point in continuation. It's not cost effective.
or immunomodulators.
Sir,
I
Both
quote
of
the
them,
same paper.
you need not co-prescribe.
But sir, in the beginning
With
we were
either
saying,
immunomodulators or you don't have to cope with.
so in the beginning we were saying don't give ASAP risk of the lymphoma. Now in the de-escalation we are saying we give the immunomodulators for the longer time.
The risk of malignancies are more when we combine the two. Now, azathioprine, normally what we are using in Indian population is a smaller dose, and my opening sentence was that the risk of lymphoma on azathioprine has been more highlighted than what actually it is. So
I was quoting the ACG guidelines, where they've clearly mentioned that in the ACG guidelines 21, that ASA is not 5-ASA is not to be discontinued in a patient who has established UC.
No, these are latest papers which are coming in.
Dr. Puri, I mean, there is data, I'm quoting this, which is convincingly shown, I mean, from David Rubin or one of people from US, that once a patient goes on biologics, 5-ASA has no role.
But that's not what is being followed. Here we are saying that the patient in success trial, they used 5-ASA plus Azoran plus Remicade. So 3 drugs. And you're saying that even 5-ASA need not be continued.
UC success trial.
I'm talking about success trial.
UC success trial is a different trial.
I think this is a one topic we can discuss later on. Finish that one.
Okay. I think
you should end now.
So I think we have discontinued a large number of patients, and this is about 304 patients that last year. We have much more this year because patients keep dropping by. And what we have found actually is that, there is a subset of patients who after stopping biologics do well for many years. So there is some change in the natural course of the disease. And I think that is the subset we should look at as to which are these patients. Final comments, of course, positioning of new IBD therapies in practice. This is how it looks right now: steroids, immunosuppressants, and then anti-TNFs or vedolizumab. Ustekinumab may fit in there for Crohn's, and then tofacitinib. But because of the cost benefit, maybe many of us are using tofacitinib much earlier. And I think that would be the more or less positioning of biologics right now. I think in the interest of time, we could have discussed much more. But thank you both the Soods, sirs. Thank you, Dr. Desai, and thank you, Dr. Shobna. And
Thank you,
everybody.
Rupa Wilson. I think we should end this session now. We had, I think, actually the way discussion goes, we can go on the whole night till tomorrow and probably replace the endoscopy session with this. So anyway, tomorrow, before we end, we'd like to thank Takeda for this educational grant to do this. And before, I think tomorrow morning, 9 o'clock, we're starting. Breakfast is at the restaurant. Satya? Breakfast is the Amber restaurant. Okay, Amber restaurant. It's in the main building. So we meet here at 9 o'clock. Thank you.
Thank you.
The time has come to change the landscape of inflammatory bowel disease in India. The time has come to change these grim facts. The time has come to review current therapeutic options and go beyond their limitations. They do not selectively target the gut and may have safety concerns. That's why we need new treatment strategies and find one which is gut selective, which could lead to long-term remission and hold out the possibility of early control. At Takeda, we've been researching biologics that could meet these criteria. And this is what we've come up with. Kintilese, the first and only biologic with a gut-selective mode of action. Kintilese binds to alpha-4 beta-7 integrin, thus preventing an excess of white blood cells from entering the GI tract. This helps to control inflammation and symptoms of ulcerative colitis and Crohn's disease. Studies show that patients tend to show a rapid response. Many achieve long-lasting remissions without resorting to steroids or surgery. Kintilese has a safety profile comparable to that of a placebo. It's been extensively studied in patients across the world in large studies that included Indian patients. It is present in more than 60 countries and is backed by over 400,000 cumulative patient years of experience. Vedolizumab has earned the approval and recommendations of global bodies. So, the time has come to change India's IBD landscape. Kintilese is here, made for now.